Well, good afternoon, ladies and gentlemen, and a warm welcome from a cloudy Cape Town. It gives me huge pleasure this afternoon to have a new speaker on our dial, and that is Dr. Nancy Kazadi. Nancy Kazadi is newly qualified from the University of Stellenbosch, and she's been at Tygerberg hitherto, and the present time is very busy organizing FIGO. Yes, FIGO. I've mentioned FIGO in the past, and as you know, that's in October, starting the 5th of October, and we look forward to having many people. Nancy, you know, we have over 500 people, South African people, registered for FIGO. Can you believe it?
I can, because it's in Cape Town and it's a fantastic location. We're very excited. We've been excited since France, so I can
Yeah.
definitely see 500 plus more people coming to Figo.
I remember you floating down that riverboat, the Lou. What's the name of that
And
river?
Lucerne.
Yeah,
Lucerne?
that's right. That's right. You went down that and you had that beautiful evening
Yeah.
floating, had dinner on the on that river, which name I can never remember. So, Nancy, you're going to be speaking this afternoon about PCOS, new insights into an old problem. And we're looking forward greatly to having new insights because there are many new insights. And you're going to be doing some presentations also at FIGO. So it gives me great excitement to have you this afternoon and also to look forward to for FIGO in October. Just to remind you that next week, ladies and gentlemen, we have Abbott sponsoring a new speaker again. We've had old speakers in the past, like Steve Jeffrey and them. So we're getting some new blood, and that's Dr. Tome Honing. This afternoon, it's Nancy Kazadi. Next week, Dr. Tome Honing, who's a fertility specialist and gynecologist, sponsored by Abbott, and she's speaking about dysmenorrhea, approaches to advancing, sorry, I'll say it again, dysmenorrhea, an approach to empowering everyday practice of the silent burden. So great things lying ahead, and thanks again to Abbott for that. And thanks also to Devon Sprake, who's organizing her. So we're going to be joined in a very short while by my co-host, who's Professor Steve Jeffrey, and he's going to be assisting over here as we moderate. Now, the topic then, PCOS, new insights to an old problem. Nancy Kazadi, can you please kindly share your slides, and a great big thank you and a warm welcome to this platform. We have over 200 people logged on, so there's no pressure for you, Nancy, and we're really looking forward to your presentation. Nancy Kazadi.
Thank you, Peter. Good evening, everybody. I don't know, can you guys see you can see my screen. I had some
We
issues.
can see your stream. Thanks, Nancy.
Again, thank you for the warm welcome. And like you said, yes, we met just because of FIGO at the FIGO local organizing committee dinner last week. And I definitely wasn't over a week, I think 2 weeks back, and I definitely wasn't anticipating presenting today, but I'm very excited. And so welcome to everybody today on today's talk on new insights in PCOS. As Peter said, I'm Nancy Kazadi. So polycystic ovarian syndrome remains one of the most complex heterogeneous conditions in reproductive endocrinology, a condition we often diagnose with confidence, yet still struggle to fully understand. And traditionally framed as an issue of hyperandrogenism and ovulatory dysfunction, PCOS has gradually revealed itself to be far more nuanced, genetically, metabolically, and phenotypically diverse. And so in this talk, I aim to take us beyond the surface. We will begin with an overview of the emerging genetic insights, exploring how molecular and epigenetic mechanisms are reshaping our understanding of PCOS pathogenesis. We'll also speak to quote unquote, the new contributors in the pathogenesis of PCOS. I will then trace the evolution of the diagnostic criteria from the Rotterdam and to more recent refinements and the growing debate around phenotype classification. And then we'll shift our focus to treatment, examining how both newer pharmacological agents and older weight loss interventions are being reevaluated in the context of PCOS, particularly in our obese patients. And then finally, we'll turn our attention to PCOS and the adolescents and PCOS and ovarian aging. Now, I'm by no means an expert on PCOS, So if anybody is or has better insight, please feel free to stop and add input. But my hope is that this session will provide you all with maybe updated knowledge on PCOS and a more sort of lens view and critical thinking in the approach of the diagnosis and management of this condition. Sorry, my technology is, let's see, next slide. So like I said, PCOS is a multifactorial disorder with poorly understood etiology. It's a condition involving complex interactions between endocrine. Sorry, I don't know what is happening.
Chris, is everything all right there, Chris?
Yes, everything is good.
It's sort of just doing its own thing, but I'll try and control. So it's a condition involving complex interactions between endocrine, metabolic, environmental, and genetic factors. Again, it's on its own mission. So if we delve into this genetic and epigenetic component a bit and explore some questions around this. So multiple genes on various chromosomes have been implicated in the pathogenesis of PCOS. And the main categories of genes involved are genes involved with insulin resistance, so IRS1, IRS2, which we can see on chromosomes 2 and 3, long arms of chromosomes 2 and 3 respectively. Other genes involved include androgen biosynthesis, for example, the androgen receptor gene on the X chromosome, as well as genes involved with hormonal regulation, so FSH, LH receptor genes, as well as other genes, so growth regulation genes, transcription factors. And most of these genes associated with PCOS are normally inherited polymorphisms, not mutations in sort of the Mendelian sense of inheritance. These genes are typically part of a polymorphic polygenic inheritance, meaning they contribute very small effects to the overall risk. Their inheritance is normal. But
Nancy, are you changing it, or is Chris changing your?
It's going on its
random.
own. It's just running on its own. I'm not sure how to not. But maybe I can end the slideshow and just share parts of my screen.
Chris, would that help, do you think?
It might
Let's
just.
try it. Let's try it.
I think it will. This might just be better. Yeah. Is that better?
Yeah, looking perfect.
Yeah. So as I said, the inheritance, these genes are typically polygenic, and their inheritance, you inherit normal genes, essentially. But these normal genes increase the susceptibility of PCOS when combined with environmental or epigenetic factors. There's no single gene inheritance, there's no single gene defect that then causes PCOS. So to bring us to our questions, what activates these genes? Are there quite a few, and there are quite a few proposed mechanisms. So transcription factors essentially are the molecular switch-on operators. And these are special proteins that bind to specific DNA sequences and can either initiate or suppress gene activities. Other things like hormonal stimuli can do the same thing, can give messages to cells to switch them on and off. For example, insulin enhances expression of androgen-producing genes and enzymes, and androgens themselves can then reinforce their own production and upregulate the androgen receptor gene. At a cellular context, it's location, location, location. Location matters where the gene is essentially. So if we're looking at ovarian theca cells, their steroid hormone synthesis gene is highly active, whereas in adipose tissue, the genes affecting insulin resistance sensitivity is then upregulated, versus in the hypothalamic neurons, where we are seeing neuroendocrine regulation that then affects GnRH secretion, affecting then the LH pulsatility. So essentially, there's no universal cascade or domino effect of PCOS. Rather, it's a feedback loop between insulin resistance, hyperandrogenism, and the gonadotropin imbalances. Now that we've explored sort of the genetic etiological component in PCOS, what is the role of the environment and the epigenetics? So the environmental factors, especially during the fetal and early postnatal period, can epigenetically program PCOS risk. And the prenatal androgen exposure may alter the DNA methylation in steroidogenic genes, leading to the development of PCOS. So essentially, DNA methylation is the epigenetic modification where a methyl group is added to a DNA molecule, influencing the gene expression without actually altering the gene sequence itself. So when a gene promoter region is heavily methylated, the gene is usually silenced or turned down. Conversely, when it's hypomethylated or too little methylation, it leads to overexpression. So back to our example of the prenatal exposure to androgens. If a fetus is exposed to excess androgens for whatever reason, either endogenous or exogenously, it may cause hypomethylation in the androgen-related gene, making them overactive, which can then lead to increased androgen production or sensitivity later on in life, even when the genetic sequence is normal. If we look to our environmental triggers, specifically obesity and high-fat diets, these can promote methylation changes in the metabolic genes. So endocrine disturbing chemicals can interfere with normal methylation during critical developmental windows. And these effects can be long-lasting and can even be passed on to future generations via epigenetic inheritance. So regardless of the DNA sequence being normal, if they've been epigenetically imprinted, those can then be passed down. Now, as a clinician myself, my head sometimes spins when it comes to molecular medicine, molecular sciences, and I was actually just speaking to Chris now about him being a geneticist. And I won't fault any of those who've lost complete track of what I've been saying for the past 5 minutes. But hopefully some of you are asking yourselves, okay, yes, there's a strong genetic component, but what then? And so to bring us back to the aim of this talk, how is this information on genes and epigenetics moving us forward into sort of the territories of PCOS management? So if we go back to here, so what is the question then that we're asking ourselves? Is there gene therapy for PCOS? And can we use genes and gene sequencing to actually screen as a feasible way of screening for PCOS? So this exploratory case study by Liu et al. Was published by Annals of Medicine, which is a peer-reviewed open access journal. It aimed to investigate the transcriptonic differences in oocytes of women with PCOS compared to their controls, and they did that using single-cell DNA sequencing. And essentially, the authors analyzed 10 oocytes, 5 from patients with PCOS, 5 from patients without PCOS, and identified 1,600 differentially expressed genes. Notably, they found that the progesterone receptor and ADAMTS1 were downregulated, while SIRT1 was upregulated. And these genes are what are implicated in ovulation, luteal function, and oxidative stress. And so the study then proposed several therapeutic agents, including reversitol, as a possible targeted therapy for patients with PCOS. So now reversitol is a naturally occurring compound that's found in plants, grapes, some wines, and peanuts. And I mentioned earlier about mitochondrial enzymes being involved in PCOS. And so this study by Biomed Central is a triple-blinded, placebo-controlled, randomized control trial investigating the effects of reversitol on mitochondrial function, on oxidative stress, and on IVF outcomes in patients undergoing assisted reproductive techniques, patients with PCOS. So what they did in the study is that they had 56 women with PCOS undergoing ARTs either be blinded to 800 milligrams of reversitol versus the placebo for 60 days. And their primary outcome was to see if there was, to look at the oxidative stress markers within the follicular fluid, looking at mitochondrial gene protein expression in granulosa cells, and then looking at IVF outcomes, so looking at mature oocytes, embryo quality, and things like that. And what they found is that there was an overall reduced oxidative stress, there was improved mitochondrial functioning, and they had better IVF outcomes. So they saw more mature oocytes of high quality embryos, but what they didn't see actually of significance was the difference in pregnancy rates, either chemical or clinical pregnancies. And so the interpretation is that there may be a window for the use of resveratrol, as it appears to enhance, as I said, mitochondrial health and reduce oxidative stress in women with PCOS, which translates to better oocyte maturation and embryo development. There are other sort of exploratory preclinical research exploring androgen biosynthesis genes, research looking into sort of epigenetic modulators to try and reprogram the dysfunctional gene expression as a way of curbing the pathogenesis of PCOS. And then lastly, to our fourth question, is this a possible screening mechanism? Is this actually a preventable condition? Unfortunately, why screening for PCOS isn't feasible just as yet goes back to what I said earlier on regarding the genes. These are normal variants within the population. And so screening for these genes doesn't necessarily mean that the disease progression will happen. And essentially also there's no single gene defect in PCOS. It's a multitude of these genes and then the environmental impact on these genes. But there are no standardized epigenetic markers just of yet that have been developed to help sort of see if PCOS will develop. But what we do know and can still help us prevent it in the long run, because even though we can't screen reliably, our growing understanding of PCOS genetics and epigenetics gives us some opportunity to help prevent the condition. Am I still on? Does anyone want to ask questions or jump in?
No, we're still with you, Nancy.
Okay, good. So if we look towards the pathogenesis of the condition, polycystic ovarian syndrome is the most common cause of hyperandrogenism in women and is typically characterized by a functional ovarian hyperandrogenism. So in most PCOS cases, there's insulin excess, which plays a central role in the sensitization of the ovary to luteinizing hormone, which then in turn overstimulates the theca cells, resulting in the excess androgen production. The androgen excess accelerates the recruitment of primordial follicles, but paradoxically also disrupts the dominant follicle selection through premature luteinization, contributing to this characteristic polycystic ovarian morphology that we see on ultrasound. And although there is elevated LH, which is common in PCOS, that is more rather a consequence rather than a cause of the disorder. And the condition is also marked by relatively low FSH levels. So relatively low FSH levels, which impairs the aromatizations of androgens to estrogens in women with PCOS. And in women with obesity specifically, there's circulating androgens, which are further converted to estrone in the peripheral tissue. And itself, estrone then has a negative feedback, and we get to where there's now gonadotropin, GnRH positivity problems, eventually all leading to this sort of endometrial hyperplasia and then the associated risks. And so now that covers the sort of traditional understanding pathogenesis that is quoted in literature regarding sort of the hormonal and metabolic pathways that are driving PCOS. But as our understanding deepens, new layers are emerging in the pathogenesis of the syndrome. And one particularly intriguing, or that I found intriguing, and one rapidly expanding area of research is the role of the gut microbiota. So could the bacteria in our intestines be influencing ovarian function, insulin sensitivity, and hormone production? So There are multiple reviews that investigate the role of gut microbiota in the pathogenesis of PCOS, which then emphasizes the interplay with insulin resistance, hyperandrogenism, and chronic inflammation, and the reproductive dysfunction. So there are findings from observational studies and animal studies that are demonstrating that women with PCOS often exhibit this reduced microbial diversity, which then alters the bacterial composition and then increases the markers of endotoxemia, all resulting in this sort of metabolic and hormonal impairment. So the key proposed mechanism here is that there's gut-derived endotoxins and the lipopolysaccharides within the cell wall, the outer membrane of these gram-negative bacteria are then released within the system and are then causing sort of this systemic inflammation. There's also thought to be a reduced fatty chain acid production and bile acid metabolism that then influence also insulin sensitivity and ovarian steroidogenesis. And there are some animal studies showing that diet interacts with PCOS pathology, but that it exacerbates this gut imbalance, providing some experimental support as the causality of actual PCOS. And so the gut microbiota has emerged as a critical contributor to both metabolic and the reproductive features of PCOS. And the intervention targeting this dysbiosis of the gut, such as probiotics, is what was investigated in this randomized double-blinded placebo-control trial, looking to see the effects of probiotics on women with PCOS. So what this study then did is that they looked at lactobacillus as the probiotic supplementation on its influence on inflammation in patients with PCOS. And the results showed that there was a significant decrease in the anti-inflammatory markers, so your interleukin 10, and a decrease in the pro-inflammatory markers, so interleukin 6 and your CRP, but that there was no great changes in your tumor necrotic factor alpha levels. But what it does show is that the probiotics can significantly reduce the inflammation and then therefore has an impact on the progression of the disease. And so this illustrates that there is, in all likelihood, some kind of microbiome, metabolism, ovarian axis interplay in patients with PCOS, and that this maybe offers a promising avenue for tailored therapies beyond the traditional endocrine metabolic treatments. This appraisal, I thought, underscored the review's value in the expanding our understanding of PCOS, but also to maybe include gut health and the systemic inflammatory consequences of imbalanced gut health as something to look at as well when treating patients with PCOS. There have been other plausible interventions like prebiotics and dietary modulators, as well as fecal microbiota transplantation. So essentially, fecal microbiota transplantation is the process of transferring stool from a healthy donor into the gastrointestinal tract of a patient with the aim of restoring this balanced gut microbiome. And so currently it's being used for patients with recurrent C. diff, but I think that there's quite a lot of evidence to suggest that there might be some influence and that we may actually be seeing more and more of this in patients, in the treatment of patients with PCOS.
Nancy, I'm sorry I was a bit late, but yeah, came in at a good time, yeah. And I think Peter and I are quite interested in this whole fecal transplant thing. I think it's quite hard to get in South Africa still. You know, I've got patients, I've got one patient who's been desperate to have this done, and she's actually ended up in Europe where they do it, but apparently they do post these fecal transplant little capsules to patients as well. Do you know of anywhere where they actually do it in Cape Town? I know Dr. Epstein was doing one in Cape Town, but I don't know if there's anywhere else in South Africa where
I've
they do
seen
it.
YouTube's telling you how to do it. You get feces from an unrelated healthy donor, and then you get a food processor and you churn it up into a sort of a blancmange, and then you use a turkey baster. And I can see Nancy thinks this is a crazy idea.
I mean, the mechanisms of doing it, I didn't think we'd be using a food processor, but okay.
I'm not coming to us for lunch.
You're not coming to using my food mixer.
No.
Okay, so then look, look, it's pretty low tech. But if you're thinking of putting E. coli into your colon, Steve, that's how it's done. I mean, this idea about of taking capsules full of feces. I mean, those things taste like shit. But apart from that, is that it's just so much more expensive. Whereas if you do the YouTube, have you? I know that they used to produce E. coli capsules at the University of Stellenbosch. I don't know if you were aware of that, Nancy. That was for seeding in certain GIT abnormalities. But why would it be so difficult to do in South Africa, Steve, if it's done that way overseas? In your patients, what do they say?
Well, I mean, I think it's quite uncontrolled, and patients can get quite sick if it's not done properly. So, I mean, it still needs to be done in a very controlled way. I think that's the main danger here, that people, and they don't recommend you do it like that. So,
Why?
well, I mean, I just think it's uncontrolled, and I don't think it's, you can maybe see them with some other pathogenic things.
I suppose so.
Yeah, but I don't know, does Nancy do?
What do you say,
What do you
Nancy?
think? I mean, here we go. We all
think
suspect
maybe
that
if we-
patients need something like this. So, yeah, what do you think?
I mean, if I don't know if the stool transplant would be first line. Firstly, I think maybe to look at addressing diet and then trying the probiotics. But if that then comes to the fecal microbiota transplantation, I think maybe the route of administration may be changed. But I also think the burden of disease of other sort of inflammatory and other gut disorders may be sort of predominant or unknown in South Africa enough for us to, transplant feces. Alternatively, they could always just grow the E. coli and look at modes of administration differently. So like you're saying, maybe with the turkey-based via the anal administration.
Nancy, the interesting thing is this. In our Thursday afternoons, every about 5 weeks, some guy we had Phil Steer speaking about the gut microbiome, and then somebody about breastfeeding. It just keeps coming back at us, this gut microbiome. So it must be important and it must be significant. If we ever talk on obesity, it's gut microbiome again. We just can't seem to get away from it, Steve.
But it is important, and I mean, I think you chase your tail if you don't
chase your tail.
Well, I mean, if you like the simple thing like recurrent UTIs, we know that the microbiome is essential, and but I think we're not doing enough research into probiotics. I think probiotics are completely wrong and unscientific. We're not using the right ones. We don't know what's in the probiotics. Patients using all these ones that we don't really know anything much about, and then again, I mean, I've started to use this thing called Cookie Fresh in some of my patients.
Yeah, I just don't like that. I've heard of Cookie Fresh, but I thought that is so off the wall, that name. Where did they get that name from?
But
have you heard
it?
of
It comes to the applicator and your patients use it, and I mean, it's new, but I mean,
that's cringe. Anyway, so I don't want your Cookie Fresh. Sorry, Nancy, we interrupted you. We went off at a tangent with fecal microbiomes. Yeah.
So if we look at the evolution in the diagnosis of PCOS, so the diagnostic approach in polycystic ovarian syndrome has evolved considerably, moving from early descriptions centered on ovarian appearance to more integrative criteria that encompasses clinical and biochemical features. So initially, PCOS was identified based on the appearance of this enlarged cystic ovary, and that was sort of 1844 to 1935, where the appearance of these enlarged ovaries meant you had PCOS. And then post-1935, we had the Stein and Leventhal syndrome, where they sort of linked these large ovaries to amenorrhea and hirsutism. 1990 came and we had the National Institutes of Health that defined PCOS based on hyperandrogenism, either clinical or biochemically, and then ovulatory dysfunction, so either oligo or oligoamenorrhea. But in their defining the diagnosis, they excluded the polycystic ovaries. And then this was more narrow definition, which focused on the classical sort of more severe phenotype. 2003 came and Rotterdam then said, nope, Rotterdam and Eshrei came together with ASRM, and they were like, nope, we need to consider that the polycystic ovaries must be included into our definition. And then this introduced a more broader phenotypes or gave us the A, B, C, D phenotypes, which then captured women with milder or hyperestrogenic forms. And of late, we have the Androgen Excess Society criteria, and this set of criteria further redefined the underlying understanding of PCOS and focuses on androgen excess as the key factor. And it aimed to then exclude milder phenotypes with uncertain long-term risks. So we can see that even with the evolution and we are changing the criteria, our understanding of PCOS still is sort of escaping us. But when diagnosing PCOS, a comprehensive approach is essential. Irregular menstrual cycles, either defined by more than 35 days or less than 8 cycles per year, suggests ovulatory dysfunction. But it's important to remember that there can still be an ovulation can still occur with regular cycles. Importantly, when making the diagnosis, biochemical hyperandrogenism should be assessed, and they say it should definitely be assessed using total or free testosterone via high accuracy mass spectrometry, which I think we lack a lot of in South Africa. And so maybe our thresholds for hyperandrogenism may be either too low or too high, depending on which test you're using. And I'm not sure if we have nationwide high accuracy mass spectrometry to help define hyperandrogenism accurately. And then lastly, the sort of diagnostic dilemma always comes in with clinical hirsutism, which we know is a strong predictor for PCOS, but we often forget about racial and ethnic variations, and also that some patients actually self-treat before they come to us, and so making the diagnosis also may be hard in that regard. However, ultrasound remains a cornerstone of the evaluation of polycystic ovarian morphology, which is defined by either more than 20 follicles, and those are preantral follicles measuring 2 to 9 millimeters, or an ovarian volume more than 10 mils in at least one ovary via transvaginal ultrasound imaging. However, in adolescents, PCOM or polycystic ovarian morphology criteria are not validated, and ultrasound also generally not recommended, especially if you have features of hyperandrogenism and irregular cycles, which is already enough to make a diagnosis. So in this context of sort of difficulty in making diagnostic evaluation, AMH has garnered increased attention due to its close relationship between the follicular activity and what we are seeing on ultrasounds. And we know AMH is secreted by granulosa cells in the preantral and small antral follicles, which are structures that are typically elevated in women with PCOS. So as such, AMH levels are often markedly increased in these patients, mirroring, as I said, the ovarian morphology that we're seeing on ultrasound. But while AMH can support the diagnosis of PCOS in adults, it should not be used as a standalone tool, because its interpretation is very depending on on menstrual cycle. We know patients with increased BMI traditionally have a lower AMH level. Age variation also then causes fluctuations in your AMH level, and then whether or not the patient is on COCs, because then that suppresses the AMH level. So again, making a diagnosis still to this day is quite hard. And the recent developments in understanding the PCOS in its clinical sort of heterogeneity also shows or highlights the importance of trying to make a diagnosis. There's increasing recognition that PCOS extends beyond your reproductive abnormalities to include significant metabolic dysfunction even among patients who aren't obese. So your thin, lean PCOS patients. And advances in ultrasound resolution and hormone assays have been prompts to call to update sort of our diagnostic criteria. So what is
Nancy?
Yeah.
So we just had a question over here. If you could choose, that's you, Nancy, choose between biochemical markers and ultrasound appearance, which would you choose, and which do you think is the most practical and perhaps the most cost-effective criteria we can use today in clinical setting?
So the most cost-effective, obviously, is the one that's most easily available, which would be our ultrasound. But I think the problem with ultrasound is that it's operational dependent. And it might not be the most high-tech ultrasound. There might be faults with the ultrasound. And there might not be a vaginal probe on your ultrasound. I mean, we have these kind of challenges in state practice. And so all of these factors coming together make it a sort of a non-specific, very difficult modality to accurately assess ovarian morphology. Whereas
so if you're in practice here and you've got a vaginal probe scan, would you say that's shall we say, the most effective, cost-effective,
the most cost-effective,
practical
yes.
way? And
Yes.
practical way. And what would you expect to see, is our question from our listener, what would you expect to see on a vaginal probe scan?
So we are looking at the preantral follicular size. We're looking to count how many preantral follicles there are. So the definition by Eshrey and ASRM is that there must be more than 20 preantral, so 2 to 9 millimeter follicles, or you can look at the traditional ovarian volume, so more than 10 moles in at least just one ovary, and not both of them combined or whatever. It just has to be one to make the diagnosis.
Okay, so you only need one ovary to make the diagnosis, and that's those criteria you mentioned are the most practical. Thank you very much.
But I will say that I think if we have standardized assays evaluating testosterone and free androgen indexes, then that gives us more sort of an objective measure of hyperandrogenism, which then makes it a bit more standardized, if we can get those assays.
Okay.
So as I mentioned, I mentioned the phenotypes earlier on when Rotterdam gave us the phenotypes. But what is evolving is looking beyond the phenotypes, looking at endotypes. So Rotterdam gave us the criteria in 2003 on how to classify PCOS based on their 3 core features, which included oligoamenorrhea, hyperandrogenism, and these polycystic ovarian morphology. And all we needed was 2 out of the 3. And then they gave us these 4 phenotypes, and A and B was sort of more classical PCOS, with B excluding the PCOM morphology. C was basically hyperandrogenism and PCOM, but you still had regular ovulation, and so it was thought to be a more milder phenotype with reproductive function that may have still been present. And then D was sort of controversial because it lacked the hyperandrogenism aspect, and the debate was about its validity. But since then, and you can see the table on the top here showing the differences between each phenotype, but we're looking further on. We're looking to see what's new and how else to better treat patients with PCOS. And so the emerging research is now focusing on these endotypes. And the 2 that have emerged is this metabolic dominant versus the reproductive dominant PCOS endotype. And so if these classifications help tailor treatment approaches, as the dominant features differ significantly between the 2. So in our metabolic dominant PCOS, the main characteristics there are your significant metabolic dysfunctions, including overweight and obesity, insulin resistance and hyperinsulinemia, elevated lipids and increased cardiovascular risk, and a higher risk of type 2 diabetes and non-alcoholic steatohepatitis. And the focus then there in the metabolic phenotype is then metformin as the first-line treatment for its metabolic issues in patients with PCOS. In the
Metformin.
yes, they
You say metformin.
yes, metformin.
Oh, wow.
Then we have the reproductive dominant PCOS, and the characteristics there are your androgen excess, so the hyperandrogenism within your ovulatory dysfunction, your irregular periods, and the potential of infertility, and then the hirsutism. And the treatment there then focuses on hormonal contraceptives, either your progesterones, and then using your letrozoles for ovulation induction in patients who are trying to conceive. But again, there are always overlapping features between the two endotypes. And again, highlights the more individual approach that must be considered whenever dealing with a patient with PCOS. This slide is basically a summary of the SRA guidelines into the management of PCOS patients with non-fertility features. And there's always a very strong focus on the lifestyle modification as a core component in the management of patients with PCOS. But not just for PCOS, because not just for PCOS, but just in general, that lifestyle promotes overall good health. And so the guideline details the recommendations also on COC use, which ones are beneficial at what doses, and you can see it's highlighted there, the lowest dose as possible, and then which one should be used as first line versus second line. And the recommendation again is that your anti-androgens should be used as a second line and should always sort of be added on to your estrogens. And not forgetting here the recommendation of metformin again. And that metformin is preferred over inositol for the management of patients with PCOS, particularly in women with insulin resistance and the related metabolic issues. And it's preferred over inositol because there's just stronger evidence and broader benefits of metformin over inositol. So it improves your sensitization, it improves sensitivity to insulin, it reduces androgen levels. It's got a potential for weight loss management in some patients, whereas inositol is more been shown to have an improved ovarian rates. Its use is quite limited. It doesn't have sort of the broad multi-use effect as metformin has. But and also very important not to forget the management of patients, the associated conditions in patients with PCOS, which include sleep apnea, metabolic syndrome, screening and treating, evaluating the patients for cardiovascular risks, which we know mental health, very, very big for these patients. They suffer a lot from depression and anxiety. And then also looking to address the risks of endometrial hyperplasia and then preventing the risks associated with endometrial hyperplasia. But for the purpose of this talk, again, looking far and beyond, I wanted to focus on sort of the new craze on the block in our anti-obesity medications, your GLP-1 receptor agonists, and their use in patients with PCOS, so your semaglutide, Ozempic, and your liraglutides. And so this is a summary on a meta-analysis, aimed to assess the efficacy of your GLP-1 receptor agonists in managing patients with PCOS. And it is the authors, it was a systematic review. So the authors systematically reviewed 4 randomized controlled trials involving 176 patients, most of whom received liraglutide or semaglutide. And again, the results show what we expect, what we've seen a lot in social media or just academically. There was a decrease in the BMI, decrease in the waist circumference, decrease in your triglyceride levels, and a decrease in the total testosterone. The effects on cholesterol weren't significant. And the overall conclusion is that there are good benefits to the use of your GLP-1 receptor agonists. But the question still is, why are we not using it sort of as a first-line agent for patients with PCOS? And I think the main reason I could sort of find
Nancy, isn't it because the cost is a factor?
The cost is one factor, but I mean, if we're in state, and they are looking to firstly, administration is maybe a factor as well. So the injections. And so they're looking to oral agents.
But also, I'm sitting
Yeah.
here in Steve's office. Here's a generic version. Did you know that
Yes.
generic versions are now available? I don't know how much it costs. Steve, how much does it
I
cost?
I just don't even know that it just landed on my desk. You know, I don't know these
I
people.
thought you were on it.
No,
So,
I think my secretary put this on my desk.
oh, your
so
secretary's on
I
it.
think it's being launched next week.
But it shows you that if the generics are out, I mean, it's
Yeah.
just a question of time before the cost comes down. Isn't that right, Nancy?
No, it's true. That's the one thing. But also the FDA hasn't really approved it for its use specifically for
Yeah.
PCOS. It's sort of like the misoprostol situation as a
Yeah.
use reduction agent.
Everybody uses it,
Code,
but
yeah,
not kosher.
exactly. So off code, people are using it. I'm not sure if anybody on today's meeting has experience and would like to maybe share. But I think one of the FDA's concerns is that the use of these agents in patients trying to conceive, especially so the weight loss happens, they then spontaneously ovulate and then fall pregnant while on your GLP-1 receptors. And what are the effects then, the long-term effects on conception, on fetal development? All of that still seems to be unknown territory. And so in patients maybe where the focus isn't conception, maybe then that seems to be not such a concern. But I think the main concern would be in patients who are trying to lose weight but also trying to conceive and then fall pregnant while on Ozempic or whatever GLP-1 receptor agonist they're on.
There might be a comment here.
Yeah.
It's basically it's actually more a question. Anonymous Teeny wants to know if you use these GLP-1s, is it lifelong or just until they get the
How
result?
long would you use it for, Nancy?
I think it also depends on what is the aim of what is a predominating symptom. What are your patient's aims and concerns? So if it's that you want to regulate your cycles and you have regulatory ovulatory cycles after, I don't know, 3 months, fantastic. But that also then just plays on a focus on not just the GLP-1 as a fix-all. It has to be a lifestyle thing because you can use it and then go back to being 20 kilograms overweight again and having to use that as a sort of permanent thing. I'm not entirely, so there are also concerns about thyroid dysfunction and thyroid malignancies with patients on GLP-1. We know about those Ozempic faces with fat loss in the face and just in general. And so there is very the sort of side effects of GLP-1s aren't extensively known to say that we can use this safely for a prolonged period of time. So I think the goal would be to either treat the hyperandrogenism or regulate the cycle or lose weight enough to have spontaneous ovulation in patients who maybe can't afford sort of the costs, the thousands of IVF and IUI and all the assisted reproductive techniques.
Nancy, we just quickly want to catch up some of there's lots of questions here. Steve, we better get. Oscar Shamangi says, what doses of metformin would you use? Can you give us a quick dose? 850 BD, 500 BD?
So I know in our setting, well, I say our setting, I'm still a Tigerberg registrar in my mind. We always start at the lowest dose, also because there's those gastrointestinal side effects that a lot of patients often discontinue the metformin because of that. So I think it's sort of tailored again to what is the starting dose? Can the patient tolerate? And does it actually have an effect? Because the thing is to sensitize the insulin. It's not a treatment of the diabetes, although we do know that they are have insulin resistance.
All right. Another question says, can you please expand a bit on the AMH? Could you just say 1 minute on the AMH that you mentioned earlier? They want a bit of expansion there.
Okay, so the AMH is your anti-Müllerian hormone, which is released or synthesized by your preantral follicles. And so it's sort of seen as, so in the fertility context, can be seen as your ovarian reserve, but actually also looks to see your ovarian response to stimulation if you're going to use ARTs. But in this context, it's saying if your preantral follicles release AMH, and if you have lots of preantral follicles, then you will have a lot of AMH. And then we can use AMH if it's really, really high to say that you are you probably have polycystic ovarian morphology.
Okay.
Thank you. Kaylin Apollos, Steve, what does she say?
Well, it's about really diagnosing the PCOS in younger populations, women of about early teens, around the age of 16, by using a clinical diagnosis, and often it's not possible to do transvaginal ultrasound.
Yeah.
You do blood tests, or should you just go straight into treating them? Where do you draw the line in this sort of context?
What's your approach to young girls?
The problem with the young girls actually is my next slide.
Oh, good.
Gee, how did we know?
Yeah.
I didn't
well,
know.
The problem with the young girls is essentially that the anovulation and the acne and all of that is part of normal normal puberty and normal pubertal development. And so there's this risk of either overdiagnosing or underdiagnosing, and it has its sequelae, right? So we expect to see sort of these polycystic ovaries in young girls. We expect to see acne. We expect to see irregular cycles. And so we can only ever say these people, these young girls are at risk. And the question I wanted to put forward is, I mean, is screening hurtful? Is screening helpful? And essentially you can argue it both ways, because as I mentioned, the diagnosis is challenging. But if you bear in mind these challenges in the diagnosis and then compound these challenges on the consequence of the condition if untreated, where do you sort of draw the line in it being helpful, in it being hurtful? So if you look at it as it being helpful, on one hand, if we screen adolescents and say and allow for early detection of at-risk individuals, we're saying we can treat this sooner. But the thing is, though, if we then screen all these adolescents, we're then potentially overdiagnosing and labeling a really young child with a chronic disease, which may cause the psychosocial problems, the stigma, and unnecessary medication interventions at quite an early age. So it's very tricky with adolescents. And the ESHRE again goes back to saying PCOM, or the morphology, you can't actually say that there's PCOM morphology in young girls until 8 years after menarche. So the diagnosis again is delayed, but it's so that we don't overdiagnose patients who don't have PCOS, and then maybe can give more time into patients to developing the condition and actually, solidifying your diagnosis of young girls.
Okay. There's one more question. I know I don't want to interrupt your talk, but these questions are flying in. Role of myo-inositol 40:1 ratio from Rupa Mudli. Does that make sense to you, Nancy?
Inositol. So I spoke earlier about inositol versus metformin. And essentially, I didn't read specifically about the dosages, so I'm not particularly aware.
Okay.
But if they have more, I'd love to hear.
Okay. Now, one quick one. Nancy, how many more slides do you have? Because I don't know how much time we must spend on all these questions flooding in.
Just
One more. Okay. Well, there's
Let's pick
time
the end
for.
of the slide to talk, and then we can.
Yeah, well, let me just quickly do that one
Okay.
for Purnima Dondu. She says most patients respond to combined oral stimulative pills, I suppose particularly younger women, but as it's stopped back to anovulatory, so should long-time OCs or move to other options. I didn't quite understand. Put it this way. Can we begin a young woman on something like Yaz or Yaz Plus? Would that be helpful? And would it spare her? Is it going to spare some of that hurt or harm, do you think, if we just do it for symptomatic relief of their complaint?
So
Yeah.
if I understand correctly, the complaint is anovulation, and they want to regulate their cycles.
Yeah, there's lots of them around. They're often in our rooms with their mothers.
Yeah. So I always ask my patients, do you want to see a period? And essentially the fear of PCOS patients not seeing their periods is what we know as endometrial hyperplasia. So we want to prevent the endometrial hyperplasia. But if the patient wants to have regular cycles and actually wants to see the period, and the mom's concerned because she's not sure where the blood is going, then starting on contraceptives in young patients is not a contraindication. And we know that with regulation of the cycle, your metabolic component also then is addressed, which then treats the sort of underlying metabolic sequelae of PCOS. So your high insulin levels, your high LH, your high your high cholesterol levels, your high all those metabolic things are then addressed as well when actually regulating the cycle.
Okay. Now, Nancy, you better finish your talk, otherwise you're never going to get to the end.
So in the end, looking at the opposite spectrum of age, and I thought it was just sort of something to think about. While we often think PCOS is a condition of arrested follicular development, there seems to be emerging data that suggests it may also confer a paradoxical sort of preservation of ovarian reserve, which then raises the questions about ovarian aging. Is there a delay in menopause? How does this delay in menopause then impact the treatment with HRTs in women who've had previous PCOS, and the timing of menopause in these women, which this article says is delayed at about 2 to 4 years in patients with PCOS, which then has to then one has to look at HRT supplementation in these patients differently to how you would a patient without PCOS. And that's so in summary, in closing, polycystic ovarian syndrome continues to evolve. Our understanding and our approach of the condition is evolving. And what was once sort of viewed narrowly as a reproductive disorder defined by ovarian morphology is now recognized as this complex interplay of genetics, hormonal, metabolic, and environmental factors. And now also we spoke about the gut microbiota and the epigenetics and its nuanced differences between the phenotypes. Essentially, what it boils down to is individualizing your patient and understanding what the main complaint is, and then working together with the patient to try and be sort of multidisciplinary and multidimensional in your approach of patients with PCOS. So thank you.
Thanks. Thanks very much. It was a wonderful overview of a subject which has got more and more airtime. It seems to be, much more discussed and given a lot of profile on social media now. Patients are talking about it. The eyes go bigger when you talk about PCOS in your consult. Are you seeing the same thing, Pete?
Yeah, Steve, some of us grew up in the era of Stein-Leventhal. Have you heard of Stein-Leventhal?
Yeah.
And then we used to, when I was a registrar, Nancy, we used to go cauterizing those follicles in PCO ovaries with gay abandon. Now, we don't do that anymore. Nowadays, there's Ozempic, there's metformin, there's the gut microbiome. There's so many new nuanced ways of approaching this problem that are beyond the sort of knee-jerk that we had in the past. And you've given us a beautiful talk, and thank you so much for these wonderful insights.
Thank you so much for the opportunity.
The downside for you, Nancy, is that now we're going to be asking you for give lots of other talks. So just keep your cell phone on, because you're going to be
But
lots of
not 2 days before, maybe a week before.
Not 2 days before. That guy Chris, he really must get with the program. So Nancy, I don't want to bully you again. So it's wonderful. You've had a wonderful talk. And unfortunately, we've just now run out of airtime. Just to remind you that next week, ladies and gentlemen, the same time, same place, we've got Dr. Tome Honing, and she is a fertility specialist and gynecologist, and she was actually from the Free State. Steve, that's where you are, aren't you? From the Free State. And she's going to be speaking on dysmenorrhea, approach to empowering everyday practice in the silent burden. And that's from Abbott. So, ladies and gentlemen, a big hand and a big shout out for Nancy. She's reminded us that she's chairman of WATOG for FIGO, and we look forward to seeing you doing a couple of talks then in October in Cape Town, the 5th to the 9th of October. There's well over 500 South Africans registered. Can you believe it? And they're the biggest block so far, Steve. So it's going to be wonderful to see all our friends there. If nothing else, you can come around for a good party. Thank you very much, Nancy. Thank you to
have a good afternoon. Thank you, everyone.
And for all your attention and all your care. Thank you, Nancy.
Yeah, thanks very much. Yes, wonderful and great to have such a great comprehensive talk about an important subject that we do see a lot of, and we all grew up with at Rescue with Zephany.
We see so much.
Yeah, so it's wonderful. And we'll see you all next week. And thanks again to Pete for his efforts and Chris too. Very
Thanks,
much.
Nancy.
Thanks
Thanks,
very much.
Chris.
Thank you.
Bye, guys.
Okay.
Bye.
Bye.